In this video, we will discuss about the interpretation of CBC, complete blood count. Mainly three cell lineages: red blood cells, white blood cells and platelets. So whenever there is deficiency of RBCs, it is anemia. If there is excess, we know it is polycythemia. Similarly, leukocytosis is increased number of WBC. If it is decreased, we call it as leukopenia. Coming to platelets, thrombocytosis or thrombocytopenia. If there are deficiencies of all these cell lineages, we consider it as Pancytopenia. And the importance of peripheral smear also will be discussed. Coming to red blood cells, and if you have observed there is deficiency of RBCs or hemoglobin, so you have suspected anemia. So in that case, the next focus should be on the size of RBCs, which will give numerous clues related to the causes of anemia. For example, normally it should be 80 to 100 femtoliters, which we consider it as normocytic. If it is less than 80, it is microcytic. More than 100 is macrocytic. So this division should be the first step in anemia related CBC interpretation. So how does it help? There are particular causes for each of these morphologies. For example, microcytic picture is seen in iron deficiency anemia, which is the commonest cause for anemia. Also, in anemia of chronic disease, thalassemia and sideroblastic anemia, these are some reasons for microcytic. Whereas normocytic picture is seen if it is due to acute blood loss, hemolytic anemias, anemia of chronic disease, or early stages of nutritional deficiency related anemias, even in the CKD. Macrocytic picture, where the size of RBCs is more than 100, is commonly seen in B12 deficiency, folate deficiency, and some of the other reasons which we should not forget are liver disease, hypothyroidism, and myelodysplastic syndrome. That's how the interpretation of the report and clinical correlation should go hand in hand. Next is about polycythemia, especially when the hemoglobin levels are more than 17 or hematocrit of more than 51. We consider this particular condition. So whenever you see such levels, try to find out the reasons among 4 or 5 common causes. For example, is it because of dehydration? In that case, there will be relative hemo concentration leading to falsely high values. Then ask about the history of smoking for long duration of time, or if the individuals living at high altitude. Otherwise, look for any chronic lung diseases leading to chronic hypoxia, for example, COPD. They might have polycythemia as the presentation. These all we can consider as secondary causes of increased RBCs. Sometimes there will be primary marrow disorder called as polycythemia vera. For this, we need to send for genetic studies. Also remember, if the individual is elderly and there are some features of malignancies, always look for renal cell carcinoma, because that is one of the reasons for polycythemia, because of excessive abnormal paraneoplastic production of erythropoietin leading to polycythemia. So these are some of the reasons which you have to rule out without fail. Coming to white blood cells, first, increased numbers. See, there are numerous differential cells which will be responsible for various acts. For example, neutrophils will be responding in cases of bacterial infections, or if there is some inflammation, stress events, steroids and malignancies. Whereas in viral infections, it will be often lymphocytosis which we see. Otherwise, if the numbers are abnormally high or if the morphology is abnormal, think of lymphoproliferative disorders as well. Whereas if you see eosinophilia, always think of allergic reactions. So ask the history related to allergies, asthma, parasitic infections and some recent usage of newer medications leading to drug reactions. So these histories will help whenever you see eosinophilia. Monocytes, again often ignored, but if the levels are increased, it is a clue towards some chronic infections, especially if you are suspecting tuberculosis or some autoimmune diseases. Basophilia, again helpful in cases of allergies. Each of these cell lines, whenever they are abnormal, think of these particular conditions and try to look for the clinical features of the suspected thing to come to the final conclusion. Coming to leukopenia, especially when the WBC counts are less than 4,000, we consider this. As we know, WBCs are the fighter cells. So if the numbers are reduced, there will be increased risk of infections. So commonly, what are the reasons for leukopenia? Viral infections, especially now the season is monsoon season, so dengue virus, and in particular in the critical phase we see leukopenia. And if there is bone marrow suppression because of usage of some medications, or if the individual is undergoing chemotherapy, radiation therapy, etc. Also in case of severe sepsis, we see leukopenia picture. And in autoimmune disorders, usually there will be multi-cell lineage deficiencies. So if you are seeing bicytopenia or pancytopenia in a reproductive age group female, always think of autoimmune disorders. Coming to the platelets, if the numbers are increased more than 4.5 lakh, we consider it as thrombocytosis. If the numbers are less than 1.5 lakh, it is thrombocytopenia, which is commonly seen in clinical practice. We all know that increased platelet count is a risk factor for thrombosis. Sometimes it is just reactive thrombocytosis, in the sense whenever there is some infection, inflammation, even iron deficiency anemia will have relative thrombocytosis. And if these secondary reasons are not there, always think of primary myeloproliferative disorders without fail. Whereas the other side, which is very common, thrombocytopenia, if it is there, there will be increased risk of bleeding. So whenever you have thrombocytopenia in report, think whether it is due to dilutional sampling error. Otherwise, always go in this sequence. Is it due to decreased production or increased destruction or due to sequestration? So the reasons have been mentioned here. So assess in the similar pattern for the easier conclusion of the cause. Whereas pancytopenia, where there will be decrease in all three cell lineages, again very often seen. So we have to know the causes. Here I would recommend first get the nutritional levels responsible for pancytopenia, commonly B12 and folate. So if they are there, we can supplement and it will be reversed easily. And next is ask for serology, because some of the infections, particularly HIV infection, might lead to pancytopenia, which is one of the hallmark of stage 3 HIV. Then ask about the history of chemotherapy leading to bone marrow suppression. So once these basic things are done as the initial cause evaluation, always don't hesitate to send for bone marrow studies, because pancytopenia often will be due to bone marrow abnormalities. For example, infiltration by lymphomas, metastasis, myelodysplastic syndromes, or some leukemias leading to pancytopenia. So along with the basic nutritional and serology investigations, the next immediate step should be bone marrow study. And I mentioned regarding peripheral smear, which is one of the key contributing factor in finding out numerous hematological abnormalities. For example, if you see cystocytes, it is a clue regarding microangiopathic hemolytic anemias. Spirocytes, again we can think of hereditary spirocytosis. Target cells in case of thalassemia or liver disease, sickle cells in sickle cell disorders. Otherwise also, the commonest one like iron deficiency anemia, B12 deficiency anemia have typical features in peripheral smear along with the numerical factors. So we can utilize peripheral smear for the diagnosis of various conditions. So overall, always try to correlate with the clinical presentation. And remember, whenever you are sending, particularly for peripheral smear to a pathologist, always give some clinical details so that it will be easier for them for the interpretation of peripheral smear. For example, you can mention suspected hemolytic anemia so that they can keep that point in mind whenever they are observing the smear to look for cystocytes. So this was very brief and basic discussion regarding CBC interpretation. So minimum this much details everybody should be knowing. Share this among all of your batchmates, especially newly joined residents, so that it will be easier for them to integrate with the advanced concept in hematology. Thank you so much.